I'm about to tell something that could save a life, and it has everything to do with a blood pressure number that terrifies seniors: 160. I'm Dr. 60 by up to 5 Zetate from Attentive Zesh. Claire Whitmore. After 2 decades as a cardiologist, I've treated thousands of seniors with strokes, heart attacks, and kidney failure whose home monitors flashed numbers like 160/90, and no one ever told them what to do in that moment. Some panicked and called 911 when they didn't need to. Others stayed home when they were actually having a stroke. By the end of this video, seniors will know 3 things very clearly. First, what a blood pressure of 160 really means for an older adult. Second, a 30-second trick seniors can use at home to decide whether it is a true emergency or a call the doctor soon situation. Third, a step-by-step plan to handle high readings safely without underreacting or overreacting. But that 30-second trick is not coming yet, because if it is given in the first minute, many seniors will write down the steps, feel reassured, and click away. That is exactly how strokes and broken hips happen, a rule without understanding the why behind it. In a moment, there will be a story about Thomas, a 76-year-old grandfather whose blood pressure hit 162/96 one evening. He thought, "It's just stress. The doctor said not to call 911 unless it's over 200. He skipped the simple 30-second check that could have revealed he was having a heart attack. Before hearing Thomas's story, seniors can go to the comments and write 3 things: age, last blood pressure reading remembered, and the highest number ever seen at home. Something like 74, last 132/80ths, highest 168/90seconds, or 81, last 150/88ths. Not sure about highest. Those real numbers matter. Thomas was 76 years old. A retired postal worker, married for 52 years, living in a 1-story house with his wife Linda. He walked the dog most afternoons, did small repairs around the house, and enjoyed watching baseball. His medical chart looked like many seniors: blood pressure usually in the 130s to low 140s/80s on 2 medications, type 2 diabetes for 10 years, last A1C 7.4%, high cholesterol on a statin, stage 3 kidney disease, estimated GFR around 48, weight 210 pounds at 5'10". He took lisinopril 20 mg in the morning, amlodipine 5 mg at night, metformin twice a day, a statin at bedtime, baby aspirin. At his visit in March, the clinic blood pressure was 138/82. Not perfect, but we'll accept this for now, his doctor said. Call the office if pressure at home is consistently over 150, and go to the emergency room if seniors ever see over 180 or 200 with a bad headache. Thomas heard, 160 is not an emergency. The doctor never explained what to do when the number was high but not sky high, or how to check for warning signs of a crisis. At home, Thomas had a decent monitor. He used it here and there, not daily. Most readings landed around 135, 145/80/85. Then, in late May, things began to change. He started feeling more tired on his afternoon dog walks. He blamed the heat. A few times he felt a strange tightness in the middle of his chest when walking uphill. Not sharp pain, more like a squeezing or pressure that went away when he stopped. At one appointment, he mentioned, "Sometimes I get a little pressure here when I walk too fast," tapping the center of his chest. His doctor listened, then said, "If it goes away when resting, it's probably just deconditioning. Seniors, slow down. Let's keep an eye on it." No stress test was ordered. No change in plan. Thomas took reassurance from that. 3 weeks later, after a tense phone call with his son about money problems, Thomas felt that same heavy pressure in his chest, this time while sitting in his recliner. It radiated into his left shoulder and up into his jaw. He checked his blood pressure, 162/96, heart rate 96. He felt slightly nauseated and sweaty. Must be stress, he thought. Doctor said don't go to the ER unless it's over 180 or 200 with a splitting headache. It's just 160. He did not stop to ask the single most important question: what is my body doing besides showing a number? He did not scan for red flag symptoms. He did not repeat the reading after sitting quietly. He did not tell his wife how different this chest pressure felt. He decided to lie down on the couch and breathe through it. Linda came in and asked, "Are seniors okay? You look pale." "Just a little heartburn," he said. "The monitor says my pressure is up a bit. I'll rest." She trusted him. They did not call 911. They did not call the doctor. Over the next hour, the pressure in his chest waxed and waned, never completely disappearing. He felt drained but did not want to make a fuss. He fell into a restless sleep around 11 p.m. At 3:10 a.m., Linda woke to a strange gurgling sound. She turned on the light. Thomas was gasping, eyes partially open, not responsive to her voice. His skin was cold and clammy. She grabbed the blood pressure monitor in panic, but he kept pulling his arm away. He was barely conscious. Linda dialed 911. By the time paramedics arrived at 3:24 a.m., Thomas was unresponsive. The monitor in the ambulance showed a deadly heart rhythm, ventricular fibrillation. They started CPR and defibrillation immediately. They managed to get a pulse back briefly on the way to the hospital, but Thomas arrested again in the emergency department. An EKG showed changes typical of a large heart attack, a big clot in his main coronary artery. Cardiologist rushed him to the cath lab, opened the artery and placed a stent. But his heart muscle had been starved of blood for many hours by then. He survived the initial event, but he left the ICU with a weak, damaged heart. His ejection fraction, a measure of pumping strength, was only 25%. Normal is 55–70%. Life changed dramatically. He could not climb stairs without stopping. He slept propped on pillows because lying flat made him short of breath. He needed help with showering on bad days. At a follow-up, the cardiologist spoke to Thomas and Linda. Those first symptoms in the evening, chest pressure radiating to the jaw, sweating, nausea, and a blood pressure of 162. That was the start of the heart attack, she said. Linda looked stunned. But his doctor said not to go to the ER unless it was over 180 or 200, she said. It was 162. He thought it was just stress. The cardiologist replied, "The number alone is not the main issue in a crisis. Symptoms plus a raised pressure, especially in a senior with risk factors, is a red light." A simple 30-second check that focused on symptoms, not just the number, would have told him to call 911 immediately. The tragedy here is not just that Thomas had a heart attack, it is that for hours, seniors in his position desperately needed emergency care and did not know it because every conversation had focused on numbers, not on the body's alarms. Now, imagine a different scenario. He checks his pressure, sentosa sontaju over novantase. He feels zero chest pain, no shortness of breath, no headache, no weakness, no trouble speaking, no confusion. He sits down, does a 30-second breathing and symptom scan, retakes the reading, and sees it fall to 148/88. That is not a 911 call. That is a call the doctor within a day or two situation. The key is knowing how to tell those two scenarios apart. Now is a good time for seniors to pause and think about personal experience. Anyone who has ever seen a home reading of 160 or higher can write 160 in the comments, along with how it felt in that moment. Calm, terrified, confused? Also helpful is sharing age and how many blood pressure medications are on the daily list. For example, 78 2 meds or 70 0 meds, just monitoring. Those details matter because a reading of 160 in a healthy, active 65-year-old who just hurried up the stairs means something very different from 160 in an 82-year-old with diabetes, kidney disease and chest pain. Now, what is actually going on in the body when blood pressure hits 160? And why can one senior safely sit and repeat the reading while another should call 911 right away? For decades, the message was, if blood pressure is over 180, rush to the emergency room. If it's lower, relax. That advice is dangerously incomplete for seniors. To understand why, think of blood pressure as the force pushing blood through pipes. Short-term, pressure can spike for many reasons: climbing stairs, pain, anger or fear, a full bladder, caffeine or nicotine. In those situations, blood pressure may touch 160 for a few minutes and then drift back down. That is not the same as hours and hours of pressure in the 160s for no obvious reason. The second piece is what high pressure actually does. It puts extra strain on the heart muscle. It batters the delicate blood vessels in the brain. It stresses the fine filters in the kidneys. When those structures are already fragile, as they often are in seniors, a sudden spike plus certain symptoms can mean real danger. 4 important differences make older adults particularly vulnerable. First, stiff arteries. With age, arteries become less elastic and more like rigid pipes. When pressure spikes, that force is transmitted more directly to the brain and heart. There is less give in the system. Second, worn-down pressure reflexes. The sensors in the neck and chest that detect pressure and adjust heart rate, baroreceptors, become sluggish with age. The body is slower to correct sudden changes, both up and down. Third, multiple illnesses. Many seniors have diabetes, kidney disease, old silent strokes or heart failure. These conditions mean the brain, heart and kidneys have far less reserve when pressure jumps. Fourth, multiple medications. 2 or 3 blood pressure drugs plus diuretics plus other medicines affecting heart rate and vessel tone change how the body responds to stress and high readings. What looks mild on the monitor may be a heavy burden on an already medicated system. Research backs up this more nuanced picture. Large population studies like the Framingham Heart Study have shown that the risk of stroke and heart attack climbs steadily once systolic pressure is above about 140 and even more steeply above 160, especially in seniors. But other research, including studies in JAMA and emergency medicine journals, has shown that many older adults who arrive in emergency departments with high blood pressure but no warning symptoms do not benefit from aggressive emergency treatment. Their risk is not from that single number, it is from long-term uncontrolled pressure. On the other hand, cardiology and neurology literature is very clear. A blood pressure of 160 combined with new chest pain or pressure, new shortness of breath, sudden one-sided weakness or numbness, new slurred speech or confusion, sudden severe headache, worst of life, sudden loss of vision or double vision. That combination is an emergency. Historically, many doctors either oversimplified and said only worry above 180 or 200, or scared seniors into thinking any 160 reading means stroke right now. Both extremes are wrong. The truth is, number plus symptoms plus timing equal sign the real risk. So what is the 30-second trick? It is a very simple sequence that forces seniors to check the body, not just the machine, before making a decision. And now is the time to lay it out. Imagine sitting at the kitchen table, putting the cuff on, pressing the button and seeing 160 over 92, heart rate 88, the mind jumps. Is this an emergency? Do I call 911? Do I pretend it isn't there? Here is the 30-second trick to do before deciding anything. Step 1, sit down properly. If standing, sit in a chair with back supported, feet flat on the floor. Rest the arm on a table at heart level. This itself starts calming the system. Step 2, take 6 slow deep breaths. Inhale through the nose for a count of 4, exhale through the mouth for a count of 6. Do this about 6 times, that is roughly 30 seconds. While breathing, ask silently, am I having any of these right now? Chest pain, pressure or tightness, especially if it spreads to arm, jaw, back or neck. Shortness of breath that feels different from usual. Sudden weakness or numbness in the face, arm or leg, especially on one side. Sudden trouble speaking or understanding words. Sudden confusion or feeling not right in the head. Sudden severe headache, unlike anything before. Sudden vision changes, loss of sight, double vision or flashing lights. Sudden severe pain in the chest, back or belly, that is tearing or ripping. If the honest answer to any of those is yes, that is not a wait and see situation. That is a call 911 immediately situation. Even if the number is 150, 160 or 170, not 200. If the answer to all of those is no, no chest pain, no shortness of breath, no weakness, no trouble speaking, no confusion, no sudden severe headache, no new vision change, then move to the next step. Step 3, recheck the blood pressure correctly, stay seated, feet flat, arms supported, cuff at heart level, no talking, press the button again. Many seniors see a second reading lower than the first. For example, from 160 over 92 down to 148 over 86, simply because of that 30-second pause. If the second reading falls into the 130s or low 140s and there are no symptoms, that is not a 911 call. That is a reason to write the numbers down and call the doctor's office soon. If the second reading stays in the 160s or climbs higher, but there are still no symptoms, here is a simple traffic light guide. Green, readings under 140/90ths in a senior who is otherwise well. This is routine follow-up territory. Yellow, readings in the 140/179 systolic range, 90/109 diastolic, no warning symptoms. This is call the doctor within a day or two territory, not 911, especially if this pattern repeats over several days. Red, any reading around 180 systolic or 120 diastolic or higher, even without symptoms, in a senior with heart disease, kidney disease or diabetes. Any reading in the 150 SBF, 170s combined with the red flag symptoms listed earlier, that is 911 territory. So the 30-second trick is, sit correctly. Take 6 slow breaths while scanning the body for red flags. Then repeat the reading. That brief pause answers 2 crucial questions. Is this number paired with danger symptoms? Was the first reading artificially high from fear, movement, or poor positioning? From there, a longer-term plan is needed. Seniors can use a home monitor on a regular schedule, for example, morning and evening for a week, to see true patterns. Keep a written log of dates, times, and readings. Bring that log to appointments and ask, given these values and my age and conditions, what should my personal safe range be? Never should seniors double the dose of pills on their own just because of one high reading. Take an extra as-needed blood pressure pill unless specifically instructed in a written plan. Drive themselves to the hospital when having chest pain, severe shortness of breath, or stroke symptoms. 911 is safer. A few common questions come up around 160 readings. What if the number is 160 once, then normal the next few times? A single isolated 160 in an otherwise well senior, especially after exertion or stress, that drops back into the 120s, 130s after resting, is not an emergency. It is a sign to keep an eye on things and discuss at the next appointment, or sooner if it happens often. What if it's 160 most evenings, but there are no symptoms? That is not 911, but it is a problem. Regular readings in the 150-160 range are linked with higher stroke and heart attack risk over time. That pattern deserves a call to the clinician within days, not months. What if anxiety is obviously driving the number up? Anxiety and pain can raise pressure, but in seniors with risk factors, chest pain or trouble breathing should never be dismissed as just anxiety without a careful evaluation. The 30-second symptom scan is still essential. Which arm should be used? The first time, pressure should be checked in both arms. The higher reading arm becomes the official arm. Once that is known, stick with that arm for consistency. And one vital instruction, never change blood pressure medication doses without talking to the prescriber. Sudden changes can trigger dangerous swings both up and down. To see how this works when done right, consider Susan. Susan was 72, a retired school teacher with high blood pressure and high cholesterol. She walked daily and watched her diet. Her usual home readings were in the 130s over 80s on 2 medications. One evening, after dealing with a sudden family crisis over the phone, she felt her heart pounding. Her face felt hot. She decided to check her blood pressure. 162 over 94. She remembered the old messages. Go to the ER if it's over 180 from one doctor, and don't worry unless it's over 200 from a friend. She also remembered hearing an explanation much like what has been laid out today. She sat down properly, feet on the floor, arms supported. She took 6 slow breaths. While breathing, she checked her body. No chest pain, no shortness of breath, no arm, face, or leg weakness, no difficulty speaking or understanding words, no sudden headache or vision change, no confusion. She retook the reading, 148 over 88. She still felt anxious, but no red flag symptoms. She wrote the numbers in her log, took a short walk around the living room, and decided to call her doctor's office in the morning, not 911 that night. 2 weeks later, a different night, something changed. Around 4:30 a.m., she woke with a crushing pressure in the center of her chest, like someone was sitting on her sternum. It spread into her neck and left arm. She began to sweat. Breathing felt harder. She reached for the monitor with shaking hands. 158 over 92. This time during her 6 breaths, the symptom scan was very different. Yes, chest pressure. Yes, radiating pain. Yes, shortness of breath. Yes, sweating. The number itself, 158, was actually lower than the 162 from 2 weeks earlier. But now the body was shouting red flag warnings. She did not lie down and breathe it away. She woke her husband and said, "Something is wrong. This is different. Call 911. Paramedics arrived quickly. Her EKG showed signs of an early heart attack. In the hospital, an artery was opened and a stent placed within an hour of symptom onset. Her heart function remained near normal. After rehab and medication adjustments, she returned to her walks and most of her usual activities. The difference between Thomas and Susan was not the number. Both saw something around 160. The difference was, Susan used those 30 seconds to scan for symptoms. She listened to her body, not just the machine. She treated the combination of 158 and classic heart attack signs as urgent, even though it was below 180 or 200. That is exactly what this 30-second trick is meant to do: prevent overreaction to numbers alone, and prevent underreaction to numbers plus symptoms. Thomas's story sits heavily with many clinicians. A 76-year-old who trusted, "Don't go unless it's really high," ignored his body's alarms when the monitor showed 162/96 and his chest was tight and aching. Hours passed that should have been spent in a cath lab, not on a couch. The lesson from that night is not that 160 is always fatal. It is that a raised number plus warning symptoms in a senior is a medical fire alarm, even when the number is below 180 or 200. Seniors hearing this now hold information that Thomas did not have: a clear sense of what a blood pressure of 160 really means and what it does not mean. A simple 30-second sequence to follow before making a decision: sit, slow breathing, symptom scan, repeat the reading. An understanding that symptoms, chest pain, breathlessness, weakness, trouble speaking, confusion, sudden severe headache, or vision changes matter more than a single number. A framework for what to do next: when it is safe to call the doctor's office, when to watch and record, and when to call 911 without delay. Knowledge like this turns panic into a plan. This information is powerful, but only if it is turned into action. Seniors can make sure a working home blood pressure monitor is in the house, with fresh batteries and an arm cuff that fits. Practice the 30-second routine now. When things are calm, sit, breathe slowly 6 times. Scan for symptoms, so it feels familiar when numbers are high. Write down the red flag list on a note near the monitor: chest pain, shortness of breath, weakness, trouble speaking, confusion, severe headache, vision changes, crushing or tearing pain. Talk with a doctor or nurse about what personal green, yellow and red zones should be based on age and health conditions. Before this video ends, 2 simple requests. First, subscribing ensures that future discussions about heart health, blood pressure, arrhythmias and medications tailored specifically to seniors are not missed. Second, sharing this message can save real lives. Think of friends, spouses and neighbours in their 60s, 70s and 80s who own a home monitor, see readings like 160 and have no idea what to do. A single shared link can mean the difference between waiting too long and calling in time. In the comments, seniors can pick one of 3 phrases to describe current blood pressure situations. Green, if home readings are usually under 140/90ths, with no dizziness or warning symptoms. Yellow, if readings are often in the 140/179 range without symptoms, and a plan to talk to a doctor soon is needed. Red, if readings are frequently high and there have been episodes of chest pain, shortness of breath, weakness, or other red flags that have not been evaluated. Those 3 words can mark the beginning of a safer, calmer relationship with blood pressure, one that respects numbers but never ignores what the body is saying. Disclaimer: the content in this video is for educational purposes only and is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of a physician regarding any medical condition. Never change medication dosage or delay calling emergency services because of something heard online.